I have an outside voice to start with, so I do worry about using microphones. Thank you, because it's not pretty out there this morning, and it says so much that you would be willing to come out into the weather and to really spend some time with us, continuing the conversation about how we move to a level of data sharing, information sharing, and coordination across our system. So thank you so much for being here. We still have other folks who are going to be floating in, and we want to be respectful of everybody's time. So we're going to go ahead and get started. I see some folks in the room who were here with us last time, and I also see folks who are joining us for the first time. So just to very, very quickly give you a quarter overview, if you will, of what we want to do. We've been talking about this for a while. How do we get to the point where we, as a local community, begin to share information that helps us across our systems of care? One of the biggest things that we are concerned about is the fact that we so often ask people the same information repetitively. And we know, especially with the trauma, that it's like undressing a person over and over and over again. And that's not the goal. The goal is to get the information so that we can be a better service to them. So I'm really pleased that today we get to kick off what we're calling our steering committee for the work around familiar faces. Those folks who are touching all of our systems, and we need information, but we also need to be able to connect them to other systems that might be able to provide even better services as a collaborative team. So all of us, we're all in it together. So I'm not going to talk long because I am excited to be able to introduce you to Ruth Simera. And Ruth is on the screen. Let me tell you just a little bit about her. And I pulled her up. It's so neat. You can find out a lot about her. I'm just going to share highlights, and I'm going to let her share the other pieces that she may want to as we go through the conversation today. She's joining us to talk about some of the next steps, some of the broader aspects of familiar faces, and how we can work together in ways that make a difference. There are a lot of initiatives out there called Familiar Faces. Many of them are focused just on how data is shared across the juvenile justice and behavioral health system. We're looking at this broadly, which is why we launched with other people in the room, because we wanted to make sure that we were providing a system of care that really included the information as well as the decision makers who were able to come together and respond quickly to needs. So this focus is on people that we're all serving. And so Ruth, I'm going to give them just a little bit about you, and I'll let you share what you would like to as you begin your conversation with us. So Ruth joined the Department of Psychiatry in September of 2011 and serves as the Executive Director of the Coordinating Centers of Excellence at Neomed. And I know that we all know Neomed, well branded really across our country. She was previously the director of the Criminal Justice Coordinating Center of Excellence, where she worked for 9 years, strengthening and sustaining crisis intervention teams. And that's where she has really spent a great deal of time with us around CIT services and really expanding the ways in which we work with our law enforcement system and helping to build out their skill set and to build out their relationships with the people that we're serving. One other thing to know about her is she has been here doing this work for us as well, coordinating the Ohio Cross Systems Mapping Initiative to improve cross systems work and responses to justice-involved persons who are living with mental illness. And that's what we're here to talk about, especially as it pertains to some of the mapping pieces, which leads to the data sharing and understanding where our gaps are, where our opportunities are, and where our own heads are around continuing to build out services in a way that we haven't before. So with all that said, Ruth Simera, I'm turning it over to you. Thank you for joining us.
Thank you, and thanks for that introduction. Am I to share my screen, or are you going to manage the slides? We hadn't actually determined that. Oh,
She's
now
gonna
I can
share.
see the group. Wonderful.
You're gonna share, Ruth.
Okay. Give me just 1 second and I will do that. Now you're going to have to let me know because I can't see what you're seeing. I can finally see you all, but do you see my slides?
Yes.
Yep, we see them, Ruth.
Okay, wonderful. Thank you. So Helen asked that I join you today, not to necessarily repeat. In fact, I'm not going to repeat what you may have heard from Dr. Stacy Behringer about familiar faces and different ways of looking at that, but to take a step back for a minute and kind of reintroduce the concept of, how do we get better outcomes for people with mental illness in the justice system, and specifically, how do we look at data and information sharing? So I'm going to kind of define the problem. So why we even do this, and then give some samples toward the end about things that actually can be done that will enhance your ability to get data, or maybe to think about where you might already have it and what some approaches might be to doing that. So on that note, I'll begin, and thanks for the introduction, Helen, and just in terms of my time here at Neomed. I will share with you, though, that prior to being at Neomed, that's really where the brunt of my community-based work was. So in addition to the last 11 years working across the state, trying to enhance practices between the justice and mental health system, prior to that, I spent 26 years in community-based mental health, actually doing that work, overseeing crisis and emergency services, developing cross-system services, everything from one county's first community-based victim services, where we worked hand in hand with prosecutors, mental health, and first responders, and then developed a lot of first responder mental health programs that were quite effective. So I'm a believer in the work because I've seen it work. I've seen numbers drive down with families, with kids with mental illness and adults with mental illness when we put the right practices into place, and we do so collaboratively. So I just wanted to share that. All right, so moving on. First, I have to acknowledge, because I never share a slide set that's entirely my own anymore. There's so many people doing this work, and we have wonderful partners. So this list of folks, the slides you're going to see, some come from any of these partners or with data that's provided from them. I won't read the list to you; you've got it. But I just want to honor the folks doing the work.
Ruth,
And
may I
then,
interrupt you for one moment?
yes.
Could you make your slides full screen? We're seeing them in a smaller box.
Interesting. Okay, let's see.
Okay, that's better. There you go. Perfect.
Even better?
Yep, perfect.
Okay. Awesome. Let me get myself out of the way here for myself. Okay. There we go. Are we now on the slide with centers of excellence?
Yep, that's perfect.
Thank you.
Oh,
all right.
Okay. Someone's asking to go back to slide 2. There you go.
Wanting to see the acknowledgements of the folks. Am I good to?
Yep.
Am I good to move on from that? Okay. Neomed's Department of Psychiatry is home to 3 coordinating centers of excellence. And I think this is helpful to know as well, because it kind of describes the perspective from which we're coming. The Criminal Justice Coordinating Center of Excellence, which is the vantage point from which I'm primarily going to speak today. The Ohio Program for Campus Safety and Mental Health, and the Best Practices in Schizophrenia Treatment Center. Now, all three centers have something in common in that they all partner with a wide array of community organizations. They provide training, education, technical assistance, et cetera, to improve local programs and practices for people with serious mental illness at the local levels. The centers also advocate at the state and local and national levels for policies and funding to support the implementation of such practices and programs. And what they really have in common is that each center is really looking to enhance the ability for people with mental illness to live quality lives, no matter where they stay. So whether they're incarcerated, whether they're living on a college campus, whether they're in the community, our goal is to try to ensure that they have access to the best possible services. So the Criminal Justice Coordinating Center of Excellence in particular is really focused on forging those collaborations in communities that will enhance the system's ability to effectively engage in programs and practices and effectively engage people with mental illness in treatment and divert them or deflect them from jail whenever that's humanly possible. So I've pretty much summed this up, right? Our mission, our goal of this center, we've been around for 21 years now, and we've been promoting alternatives to divert people from the Justice Center in all of that time by encouraging collaborative relationships. We believe that's really the bread and butter to all of it. And also, of course, through the promotion of and utilization of best practices, but you really can't use best practices to fidelity and to great outcome without that collaboration. So, and these are the values. If you've participated in any of our sequential intercept mapping exercises, these are the values that we try to bring forward, that we ask communities to engage in, even in your basic discussions, right? To keep hope in mind, the notion that things can get better. And I typically quote Dr. Fred Fries, who died several years ago, but was well known for saying that there's never been a better time for people to have a mental illness. And what he meant by that was that we know so much more today than we ever did. And we know what works. We just are challenged to implement those things that work. So that's why the collaboration is so important. Choice, self-determination. We always want to keep that in our line of sight as much as possible, right? And I'm sure the folks that are representing the mental health system there today live and breathe that every day, trying to make sure that your clients can make the choices they want to make for their lives. We all want respect, dignity. We want to be heard. The notion of abolishing stigma, so that negativity that has grown around addiction and around mental illness, and of cutting away at that and looking at mental illness as the health issue that it is. And if you all are like me, we've all had family members and friends who have maybe not had a mental illness, but most of us have somebody in our lives who've had a mental illness, but even somebody who's just been really sick. People who have multiple illnesses and become really ill in their lives, they have a tendency to behave badly. And that cuts across illnesses. So if we look at it that way and we begin to think about the stigma associated with mental illness, it's really an unfair one, right? So we work to use person first language. That's one way to begin to diminish stigma, by referring to people by name, by referring to people in the first person, as opposed to, for example, saying someone is a schizophrenic, saying that she lives with schizophrenia or she has schizophrenia, because it doesn't define us. And then, of course, we've all been engaged in, I think, greater work towards celebrating diversity. The world's a better place with a lot of different people in it. But we also need to learn to understand those things about one another, because somebody's ethnicity, somebody's culture can really affect how they display their mental illness or how they think about it or the choices that they want to make. And always keeping in our line of sight the notion that recovery is possible. And in fact, it's likely for most people if they get the right treatments and they're able to make the choices that they need to for their lives. So having said all of that, that's my cheerleading is over, and I'm going to get to just some quick data. It's important to look at this from a historic lens. And I've got up here 2 graphs. And so this shows that just since 1980, I believe, yes, the adult correctional population, just including those probation, prison, parole, jail. So the people that have gotten further down the line in the system. And you can see looking back to 1980, not that those numbers were small, but they sure look a lot smaller on that graph, in terms of a couple million people total involved in the adult correctional population across the country. And then you look at 2010, and we're seeing now well over 7 million, more like 7.5 million people. So dramatic climb over this 30-year period. It's helpful to see the downtick that began to occur over the course of the past several years. And I added just yesterday, they finally put out the new slide, but they didn't show the whole history. So I wanted to put both of them up here because we have seen a downtick in incarceration and in probation, although it's ebbed and flowed in different parts of the country. The second graph that you see that shows that downtick only goes back to 2010. So if you used only that graph, it looks like, oh my goodness, we were doing such a good job and things are decreasing. But when you look at it historically, it puts it in perspective that we're nowhere near back to the numbers that we were in 1980, not even close. And that sharp little downtick that is on that second graph is from the pandemic. So we haven't yet seen, and we don't have data to show us what's happened over the past few years. And it'll be very interesting to see what comes over the course of the next 5 years or so. But the message is we incarcerate a lot of people. And in Ohio, we are notorious for putting people on probation. We have one of the highest probation rates in the country. I think we're ranked 3rd or 4th in the country. Related to mental illness, this is a glimpse at the population set, individuals with mental illness in the general population. So not the incarcerated population yet. And you'll see variations on these figures, but as a general rule, about 16% of the general population has a diagnosable mental disorder. About 5% of the population has what would be considered a serious mental disorder. And then when you get down to those that are really serious and persistent, so very severe, that's only about 2.5% of the population. When we look at that same population in jails and prisons, however, so on the left there is the 5% of folks in the general population with a serious mental illness. In the correctional population, however, about roughly 17% of individuals have a serious mental illness. And if you add to that the co-occurring substance use disorders, now you're looking at about 3/4 of the population. And those numbers are actually higher if you only look at local jails. It's not uncommon for a local jail to report something closer to 26 to 35% of their population having a serious mental illness. And for women, those numbers are even higher. So in prisons, it tends to be about 30% of women have a serious mental illness. And in local jails, we'll see up to half of women that are in a local jail have a serious mental illness. Women come to the justice system through different pathways than men, which is a whole other conversation that we can have another day. All right, so to finish that off kind of with the Ohio story, how do those numbers play out here in Ohio? They play out to be fairly true in Ohio. Even with the nice decline in folks in our Ohio prisons, when I was doing this talk 10 years ago, we had well over 50,000 people in Ohio prisons. A lot of work has been done to change that. The pandemic also changed that. The work that hasn't necessarily caught up is what happens in the community then to help those individuals make a good transition and to lead healthier, more meaningful lives and lives they want to live. It's always a game of catch up. But here in Ohio, you've got over 43,000 folks in Ohio prisons, and you've got less than 1,000 people in your psychiatric hospitals. When we look at those figures, we have to break that down. But the long and the short of it is we don't have current data from the Ohio Department of Rehabilitation and Corrections, but the data has stayed pretty steady in that those individuals who are classified as having a serious mental illness and receiving services equate to about 10% of that population. And while the population has declined by 15 to 20% over the past several years, the proportion of people with serious mental illness has not. And in the majority of states across the country, last I saw it was 44 out of 50. There are more people with mental illness in jails and prisons than in the state mental hospitals. So, and I apologize, I said 10%, and I was reading myself backwards. There's about 23% on the mental health caseload. I was meaning 10,000 people. That was the mistake that I made. So there's about 10 times more people with serious mental illness in prisons in Ohio than there are in the psychiatric hospitals. Right. So what do you do about that? Right. There's no single solution to the problem that we call criminalization of people with mental illness. People move through the criminal justice system in fairly predictable ways. We know that. And it's pretty well agreed upon that we need to attack this problem from a variety of levels and a variety of directions. And the sequential intercept model was created back in 2006 was the original paper came out, and our criminal justice CCOE was established based on the framework of the sequential intercept model to address this problem. And so here's that model in the funnel approach, which I think is the most illustrative approach. I'll show the linear version of it in just a minute, but particularly for your committee thinking about familiar faces, this funnel model is probably more useful because the funnel model accurately portrays the notion that you can intercept or intervene with or have contact with more people the earlier that you are in the justice system, right? Law enforcement, emergency services, they see everybody. They have to. Everybody comes through them. That's where it all begins. So that's your greatest opportunity. When you look at interventions, when you begin looking at data, that is the most important intercept to look at first. After that, then, intercept 2, when now that a decision's been made to arrest, there's an initial detention, maybe an initial hearing, typically. That's kind of the second layer. So more people are going to funnel through there than in intercept 3, when they're actually having to go to court, or maybe they're spending time in jail, forensic evaluations are occurring, versus then intercept 4, when maybe they've already spent time in jail or an institution, and now they're going to be reentering the community. And intercept 5, where people are on community supervision. I do want to acknowledge here, and this is important for your group. It's not as important when we do sequential intercept mapping, but for your purposes, you probably want to think about intercept 5 before intercept 4, because people do go from 3 to 5 pretty frequently in terms of being placed on probation and never having spent a night in jail. Plus, people that spend time in jail spend very, very short pieces of time in your local jail. And I can talk a little bit about that. There are still ways to utilize that information to think about flow and think about the number of people that flow through. But also there are a lot of people at Ohio on probation. So I would talk to intercept 5 up before 4 for your purposes. This is the linear model, probably the one you're used to seeing. It's the one that we use for mapping because it helps to show flow, and we can kind of see how people are moving as opposed to looking at numbers. If I were looking at numbers, I'd be using probably that funnel model. And then I also want to acknowledge that the updated version of this includes intercept 0. However, we don't quite utilize this version utilizing intercept 0, because when the SAMHSA's Gain Center came out with this national model and added intercept 0, it really only added the crisis continuum, whereas the original paper about the sequential intercept model clearly talked about the ultimate intercept being an effective and accessible mental health system. And I would broaden that even more to say healthcare and social service system. So we look at intercept 0 as anything which can actually prevent contact with intercept 1. And we know that that's more than just crisis services. In fact, we would hope it'd be a lot more than just crisis services, and that crisis services would be utilized for true crises. So that we're talking about housing, employment, family involvement, other social services, whether it's your local library or vocational services, any variety of things. Peer support services would be an intercept 0. So anything in your community that really helps people from touching upon that sequential intercept model, which is really meant to address the justice system. I'm going to pause there for just a second. Take a breath, because I'm going to get into some detail around the role of data and information sharing and stepping up, just to see if there's any comments or questions.
Anybody have a question for Ruth at this point? And we will have time for questions when she's done as well.
Okay. Thank you.
Ruth.
Sure. So Montgomery County is a stepping up county. And you had a community stepping up meeting back in April of this year. The role of stepping up in terms of data and information sharing is that stepping up really requires, strongly encourages, but if you're going to do stepping up, it's really about being able to measure the number of people with mental illness in the jail, because the goal of stepping up is to reduce that number. You can't reduce that number if you don't know what it is. So incidence and prevalence of people with mental illness in your jail. So there's got to be measurement, right? The other role that data plays in this, besides just having measurement, is that you want to develop intercept specific interventions and measure outcomes. So these are going to be your responses to your measurement. So you determine how many people are flowing through your county jail and get a sense of where they're coming from, how they're getting there, and design some interventions that you think will help reduce that. So that's your response to that first measurement. And then you're going to continue to measure that to see if it's working. The other thing is cross-intercept efforts. So those are the interventions and related outcomes that tie your intercepts together. So folks working together on warm handoffs, identifying gaps between intercepts. Where are people falling down between those intercepts? That's what the sequential intercept model was really designed to do, was to take a look at opportunities and those handoff opportunities to see what was happening and to develop responses that were measurable that could have a positive impact on people with mental illness. And then, of course, case discussions and management. So once you're seeing what those outcomes are like, getting people together who are involved in those specific intercepts and talking about individual cases. So we're looking at aggregate cases first. How many, what can we set up that could affect the group? But then you've got, and these are often your familiar faces, those that really need individual approaches in addition to what you've set up. So related to stepping up, just as a reminder, these are the 4 primary goals, and therefore the 4 things that stepping up would urge you to measure. So the number of people with mental illness that are booked into your jail. Are you able to get that number? If you don't yet have that number, you can't really even get started on your stepping up work, because the goal is to reduce that number. So that's point 1. How do you get that number? And there are a variety of different ways to get that. Secondly is to be able to measure the length of stay for people with mental illness in the jail, because your goal is to shorten it. Are you able to measure that length of stay? In order to be able to measure that, you have to have accomplished number 1, which is identifying that number first. And so forth down the line. Each one builds on the other. The third layer is the percentage of people with mental illness in jail who get connected to the right services. You have to know who they are first. And then the fourth is to lower your rate of recidivism. So that's your familiar faces, the people that are going to be recycling through. But you've got to have these other three numbers before you have a hope of measuring whether or not recidivism is changing. So I can't overstress the importance of data and information at each intercept, because you can't confidently identify gaps in services and incidence and prevalence of the target population if that can't be measured. Many of you, I would imagine, have participated. I can't really see the faces in the room, but we have been in your community twice to do sequential intercept mapping. And one of the activities that many of our Stepping Up communities have used to get them started is the sequential intercept mapping. Your county participated in sim mapping a couple of times, but for those who did not or haven't participated at all, I'll briefly describe it. It's a 1.5-day workshop based on the sequential intercept model. And using that linear model that I showed you, we create kind of a local cross systems map. It's more of a flow chart that illustrates the flow of people with mental illness making their way through your justice system. Key stakeholders come together to share the information that's needed to understand that flow. And through the course of that conversation, as well as some sharing about promising and best practices, we identify the opportunities, the resources, and the gaps for addressing people with serious mental illness and trying to divert them to treatment when that's possible. The group identifies usually 4 or 5 priorities for change that they want to begin working on to get started, and then action planning ensues. This graph shows you across the state of Ohio, across 31 of the counties that have participated in the adult mental health systems mapping, what the priorities are that have emerged from those 31 counties. This will be updated soon to have 2 or 3 more counties included in this. But you can see that the number 2 item is about data and information sharing and screening. Screening is really a big part of data. So you're not alone in having struggles with data, with trying to think about how do we identify these familiar faces, how do we impact a difference. It's a common issue. So 22 out of the 31 identified this as a priority in some fashion or another. And you'll see that I'll show you from your own community the things that tied you to that priority. So this was your map done in 2017 with your COAT, your Community Opioid Action Team. So that was the flow chart that emerged from that mapping. But then the priorities that emerged from that are here. And the one item that related to data and information sharing was the jail reentry or linkage. So your group wanted to establish some jail reentry services and linkage. In thinking about doing that, one of the core components of that was going to be able to have a count, right? Some record keeping of who coming out of jail was linked to services. So it's a soft tie to data, but a tie nonetheless, and a really important piece of data that could emerge from that. And then when you did your adult mental health, criminal justice systems mapping a couple years later in 2019, this was the flow chart that resulted from that. And these were your priorities. And again, here, highly related, number 5 was information flow and case planning at jail intake and discharge. So front end and back end of jail. We were very excited about that, because if you were going to look at information flow from the front end and then also look at discharge planning from the back end, that hopefully, we were hoping that was going to enable you to really capture your jail data. And I know a lot of work got done on that front. I don't know where that is at today, but we were excited about that. So in terms of now, how do you go about this, right? So what are some possible next steps? It does take collaboration. So the slide is titled Collaborative Interface because that is so important. The promising and best practices associated with a focus on data are both about identifying where the data currently exists, but then also identifying the places where you can create mechanisms to get data, right? So the next two slides you're going to see, and these are just examples. This is not an exhaustive list of possibilities. But first and foremost, if there's a possible way to identify where information currently does exist so you don't recreate the wheel and you can learn from one another, that's always the best. But the second, moving on down to starting with like CIT contact sheets, these are things that you can do. So you have a fairly robust CIT program in Montgomery County. There are model CIT contact sheets that we utilize around the state in order to track data from law enforcement encounters with people with mental illness. And there are some different ways of managing those contact sheets. But the most important thing probably that emerges from those contact sheets is setting up a mechanism for those to enable referrals to your mental health system. The contact sheets alone are good data. They're great data for law enforcement to really digest and analyze how well they're responding to people with mental illness. And then they can look at how often are they referring, how often are they arresting, how often are people being handled with force, et cetera, et cetera. And then with the number of referrals being made to the mental health system, then what's the follow-up there, right? I receive a mental health referral from law enforcement. I can report back in aggregate in de-identified fashion to you. Let's say I'm representing an agency. I can tell you that I got 87 referrals from law enforcement this month. And here is the aggregate result of those referrals. Here's what's happening with those justice contacts. That is really important data, right? If law enforcement, on the other hand, needs to arrest a person and a referral's not made, they go to jail. What's happening at booking? Is screening being done at booking? A lot of jails have moved to doing kind of higher end medical evaluations with people with mental illness instead of the screening at booking. Unfortunately, the majority of people aren't there long enough for that to occur. So that jail screening is still really important at booking. We strongly encourage it. If you're not, I believe your county was doing it, but if you're not, we would encourage that. But that's also a data point. So how many of those folks, how many people coming through the jail door are being screened positively as likely having a mental illness or a substance use disorder? We had one community that they had no services available, small community, absolutely nothing available, but they instituted the brief jail mental health screen at booking. And all they did for 6 months was throw those screenings in 2 boxes. One was a yes box, one was a no box. The yes box was the box that indicated that, yes, this person needed further assessment and evaluation. The no box was there was no indication. After 6 months, I mean, they were sitting there with these 2 boxes. Now, what do we do with this? Well, the answer was count them, count them. And now you have enough data to say, well, if we had to follow up with these folks, if I needed a person to help make connections with these people, if I needed a person to refer to services, et cetera, what level of FTE do I need for that number of people? And they were able then to write a proposal. And in this case, it was to the mental health board. But now they had data. And so now they could get a person in the jail to do some follow-up with these folks and to link them. So it's just one concrete way of utilizing really basic data. Having management information systems that identify people, and I know that you do this in Montgomery County through your mental health board. You have been identifying for years people that were in jail that were also clients within your system so that you can identify and relink to services, right? It can also help to inform those pretrial functions. And in another training we did recently, we really advocate strongly for very early legal counsel for people because a lot happens very early in the process and help is needed by individuals with mental illness to navigate those things. But having linkage when somebody is going to be released from jail is really, really important because it does reduce the risk of death upon release. And then these are just some additional things. I won't belabor the point, but court supervised release is another good place to get a head count. How many people are being put on court supervised release? What are the outcomes of that? Do you have a court notification system? Because court notification systems do improve appearance rates, but even having that system that says this is how many people got reminders or received their reminders to come to court. Discharge planning, if you have documentation of discharge planning at the jail, that in and of itself, those pieces of paper, right, that's data. How many people, excuse me, are you following up into the community? So how many warm handoffs are there? Is there collaborative case management occurring? Do you have somebody that can do check-ins? That can create data. And then specialized probation can create wonderful data. Simply having it, how many people are on specialized probation, but then within specialized probation, looking closely at that data. What is the case size? Is it as small as it should be? How many collaborative contacts are made? How many client contacts? How much participation in mental health services, etc. I'm going to stop there. And actually, I'm going to stop sharing my screen so I can see the group.
Okay, I know you all have agendas in front of you, but because we get a little bit of a late start, we're going to skip ahead to the question part because Ruth does have a heart out at 9 o'clock.
Yes.
Oh, cute kids, Ruth. Who has a question? And we are recording this too, and it will go up on our YouTube channel later today.
So one of the questions I have is just coming from the point of, because I'm in the probate court. So we tend to have individuals who may not have entered the criminal system yet. And one of the things I guess I'm concerned about tracking is we often have officers who recognize the mental illness and instead of arresting the individual due to the pink slip, take them to the hospital. And trying to figure out how to track those numbers, I think, is something that gets missed a lot of time. And I was wondering if you think it's possible to include that in the rest of the tracking data.
Would you say that again? I'm not sure I totally followed that.
Sorry. So we oftentimes trying to keep people out of the criminal system. For instance, an individual is, basically it's like a criminal trespass or something like that. We have officers recognize this is a mental illness issue and tend to pink slip them to the hospitals, trying to keep them out of the criminal system. And trying to get those tracking numbers, I think, is a sort of important in our community because we do have a lot of individuals with mental illness who are going through that versus and trying to keep them out of the criminal system. But I don't really have the data tracking on that right now. Is that something that you think can be incorporated when we're dealing with the criminal system as well?
Sure. So if you're talking about officer pink slips, if you're using a CIT contact sheet, those would be tracked on there. Am I answering the question? Yes. And that's a pretty basic piece of data that we would want to look at. And communities that are using CIT contact sheets do track whether or not they're using a civil commitment process through law enforcement and where the person goes.
Ruth, if you want to stop sharing your screen, I think you might be able to see our group too. That might be helpful.
Yeah. I can see your group, but I can't seem to stop sharing the screen. It is not giving me that option. I've been trying to do that. And
it's okay. No worries. No worries.
Let me see if I can.
So
the menu.
While you're doing that, I don't have much of a voice this morning, but I just wanted to jump in and say, and we won't spend too much time on the pieces that we can talk about here after we lose you on the Zoom, but we do get those daily reports from DPD. So we can track it on the city side in terms of the number of pink slips, because I receive a report on a daily basis. And so we just need to broaden that and be able to capture that working with our data partners. Yeah.
Dave Brandon, probate judge. I just have a question. I buy it. I buy everything you've got up there. What counties have you identified that they're successful at accomplishing what we're trying to do? And what platforms are they using and what mechanisms? Like, I want the playbook for those counties that are successful.
Yeah. So unfortunately, there isn't a playbook. So here's where this gets really sticky, right? Each county has had to come at this in its own fashion. There are certainly products out there that you can buy, but unless you know what it is and who it is that needs to put in the information and what the meaning of it is, those products aren't particularly useful. Johnson County, Kansas is a good example where they created their own. They built it from the floor up, kind of a piece at a time as they learned what they needed to have in it. And they had somebody local create it for them. We, with our CIT contact sheets, we're utilizing a company, but they're building it around what we're telling them we need to know. And that's after 20 years of learning about it, right? Stark County in Ohio is doing something interesting in that they have a criminal justice information system, which many counties do, which was really for the courts more than anything, right? But what they figured out was that they could give law enforcement access to input CIT contact sheets and lead contact sheets, so the law enforcement diversion contact sheets, that information into that system. They could set up permissions for mental health every day to check that system to pull out all new contacts. And then within their mental health system, they now require their crisis services to follow up with each of those individuals within 24 hours. But the law enforcement cannot see the mental health piece. So there's HIPAA protection there, and that mental health is separated. So each community has had to look at this kind of through their own lens. What are their resources? But first of all, who are you talking about? When you talk about your familiar faces in your community, who are they? Which intercept points are really highly engaged in that? And are they already having discussions? I understood you do have a group that's been meeting. That's probably your richest source of information at this time. What are they learning from one another about those individuals that they're discussing? And if they were going to set up something, what would they set up first? Because there's not a magic pill. There's a reason that no one has bought into any one platform across the country, because it just doesn't really work unless you know what it is you're tracking and who's inputting information and what you're going to get out of it. But there are people doing good work, and I think that you can learn from.
Who else?
Hi, good morning. I'm coming from the hospital emergency department environment. So my question is, how do we integrate that piece of intellectual disability? I appreciate that you spoke about substance use disorder and the crossover there, but I see a lot of people with intellectual disability, or at least the inability to critically analyze situations, coming in on a pink slip to avoid the theft or some other thing for and what turns out to be a medical evaluation. And so that intersection is real in our environment. And sometimes the number of touch points for those people is super high. So I just wanted to hear a little bit, this may be more of a local issue, but what your experience has been with that crossover.
Yeah, and there's, increasing crossover there. And in fact, Helen can tell you, we did a recent training for assigned counsel and public defenders with part of the focus on that very thing, because it is challenging, it's complicated, it's not straightforward, but it does take good collaboration across systems to identify those individuals, to make sure that you're training law enforcement well on recognizing when something might be an intellectual or developmental disability, and on how to think about that and what the resources are for that, what the options are for that. I wish I could just, tell you here's how to fix the problem, but it really is about collaboration and making sure that if you're not already, and I believe you are, involved in your local CIT training, involved in any cross training that occurs in the criminal justice system, to make sure that people know what the resources are, but I think more importantly, the recognition piece and understanding of what it is that they're interacting with and who they're interacting with and what the needs might be.
Any other questions? Ruth, are we able to share your presentation with this group?
Of course.
Okay, great. And so I
And
can
I
send
wish I could stop
everybody.
sharing screen.
Oh, no, we're good. One of our smart techie people fixed you all up. You're good.
Okay, good.
Any other questions before we have to let Ruth get on to her next meeting?
Quickly, one of the things that Helen and Kimberly and I have been talking about is whether or not doing a kind of a modified sequential intercept mapping to take a look at data would be useful. I think it's something to consider, but I know Kim is going to talk with you about another opportunity at the national level for a learning collaborative. I hope that your application is accepted for that learning collaborative, because I really think learning more about familiar faces and about what's happening around the country and different ways of thinking about it and looking at it would be very useful for you before making decisions on how you want to approach it. Because like I said, if it was just a one size fits all, everybody would be doing it already. And unfortunately, it is just not.
Ruth, sincere thanks to you. This has really been informative. I think it helps us to broaden our thinking around the initiative, and in typical Montgomery County style, looking at it in a very innovative and kind of futuring way. So we do appreciate your time this morning. We know you've got to get to the other meeting, but then we will be doing the follow-up and talking about the data mapping piece and the learning community. So thanks
Great.
again. Stay
Thank
well.
you. Thank you.
Good morning, everybody. I'm going to pop up here for a minute, but first off, I just have to say that I always feel super energized after I hear anything from Ruth. So I most certainly can appreciate what was presented today and can let you know that some of the things she spoke on, we are in fact already doing. And that's exciting. We have a great community that we work with. So I wanted to be able to talk with you about this learning collaborative, but I do have to share this as well, though. Last night I was sitting in my room and I thought about all the bullet points that I needed to share. Okay. But then I had to make it personal and passionate. And it ties back into even what Helen has said, what Ruth was speaking to, is the fact that behind every number and behind all of this data are people. And I reminded myself, even with CIT, what I say to the officers on the first day is, what's your why? So we're all here. We all have a reason that we're here. But I had to remind myself of all the Adams, all the Sarahs, all the Roberts that we've been working with for years and years and years. Some of you probably even know who I may be referencing when I'm saying those names. We are all here for the same purpose, and that's for the familiar faces in our community. That's why we're here. That's important to me. It's important to you. It's important to you. I know that. There's passion here. We have passion here. So let's channel all of that together and work together on this. We have familiar faces, and I'm excited to tell you that we've been having case consultation meetings. We've had 2, so we've been doing 1 a month. We have another one that's scheduled for next week. What we've been doing is inviting individuals that are involved with those particular individuals, our consumers,
to meet and talk through the supports that they need. So when I heard Ruth talking about, why don't you go to that group of people to identify what are our next steps? I thought, we have that group of people. So I want to share with you the positives that we've identified is that every person, which is 2 right now, that we have been able to have these case consultation meetings with, the one individual is getting connected with a group home. That's huge. We're talking about pulling together 5, 10, 15 people. And the collaboration that I saw was unprecedented. It was phenomenal, but that's what this is about, guys. And the other individual is now on an injectable and they're stable. That's from 2 case consultation meetings, just 2. And what I also can tell you is that the flurry of emails and communication after that first initial meeting, I was just blown away. I didn't even have to respond to them. I just watched in amazement. You guys are phenomenal. So I want to be able to talk a little bit about this fun learning collaborative. I'm going to step back here. Oh, I can see myself. Hi, Kimberly. This is great. So as we are all here this morning, what are next steps? Can you guys hear me? Oh, Tristan's like, yes, girl. Next steps really is that we want to be able to put together a group of all of you. Maybe not all of you. Maybe I'm being dramatic because I get really passionate, but we want to be able to put together a group of stakeholders, okay? To be able to meet to talk about the things that Ruth was referencing. What's our data? Like, Bobby, what data do you have? Teresa, you know, what data do you have? Lisa, Beth, our other Teresa. We've got Sarah here. What data do you have that you can share? What data do you need? And how do we need to utilize that data? That's the whole point of this learning collaborative. And I'm going to tell you something else, guys. Whether we get into that cohort or not with SAMHSA, we're doing this. Okay? So I will be putting together an application to the GAINS initiative, and it's actually called, let me look at my notes here. It's data-driven strategies for reducing familiar faces. So I'll be reaching out. I've already connected with several of you on this, and I will be continuing to reach out. So we have a timeline. Does everybody have their timeline? Right here? Okay. This is the timeline that we at the Adamus board are following, whether we get into the cohort or not. Okay. And in a minute here, my partner, other director, Tristan Ball, is going to come up here to share some of the finer details around the dashboard that we already have. So when I listened to Ruth this morning, I'm excited because we're already doing a lot of this. So we're going to have a kickoff in February. Prior to that, I will be reaching out for letters of commitment, and that is for the actual application to SAMHSA, okay? Once again, whether we get in this or not, we're doing this. That's that collaboration. We can't do this unless we work together. We will also be doing meetings monthly. We're going to have technical assistance. We're going to have subject matter experts. The culmination of all of this, and it's going to take time, is to come to a place where we're able to identify how we can support the familiar faces in our community to reduce recidivism, to get people in a group home like we just did. Right, Jen? So that's the ultimate goal. So I want to be able to pass this on to Tristan to be able to share. We already have a dashboard, guys, that we utilize. So you're up.
All right, I'm not doing full screen. I don't want to see myself here. A lot. All right. Okay, so where I'm coming at this from is really on the data sharing piece. So if you ask me about anything else, I'm probably not going to be a lot of help, but I do have a little bit of experience in data sharing. As Kimberly had alluded to, we already have a dashboard that we use in some regard. It's our high utilizer dashboard, and Ascend has really overseen a lot of the work with that. We've had a great partnership with a lot of the organizations here. And we really want to look at how that can be useful to every organization to get the information that they need, information that they want. The first step of that, as Kimberly had talked about, was really these kickoff meetings that we're going to have with each stakeholder group. And what we're going to be doing is looking at data collection. So this is an exhaustive list, but obviously if we have more questions, let me know. But looking at what data does each organization have? What data is each organization willing to share? To what extent? What stakeholders or positions are they maybe willing to share data with? What laws and regulations does each organization have to be mindful of when they're sharing and receiving data? Because we certainly need to know that. But then seeing, is there any way that other counties or other organizations have kind of come around those in a way that is still legal but helpful to others? What data do you need that you don't currently have access to? Does that data even exist? If it doesn't exist, let's come up with a plan. How do we start collecting that data? And then what does each organization need that data for? Maybe there's another way that we could come around that. What data would you like to access as just a nice to have? Is there aggregate data that would be useful to you that you don't currently have access to? Are there other pieces that could maybe be useful as well? What data do you currently have access to from other organizations, and what is it used for? Tazina and I are currently working on an initiative in the county where we're working with both Children's Services and Juvenile Court and learning how, while we may not have access to the data that they're using, how the two of them work together to be able to access information from one another. So it's kind of coming up with those creative workarounds with partnerships that maybe already exist, that the Adamus board doesn't necessarily have to oversee, as long as each party's getting the information that they need. And then overall, how are we going to define success as a collaborative? And I want to hear from each organization, what is going to make this successful? Because we all might have different ideas of success and our own goals. What will be our measures? So that's be data driven, right? How are we going to measure success? Both process measures, short-term, long-term. We really want to look at this holistically and make sure that everybody is getting exactly what they need. And how we can bring partners together to do just that, and where the Adamus board fits in. What can we do that's innovative? What ideas do you have? And obviously, if anybody else wants to take a leadership role in this and kind of guide us, we're not going to be the experts in all of this. And we know that. I think I say that at every single meeting I'm at, is getting the input of others, because we want to make sure that, we are getting your feedback and you're really driving this. So with that said, I think I'm in charge of doing next steps. We are going to have the kickoff calls. It says kickoff calls with team lead. So if you have one designee from each organization, that's great. In true like SAMHSA grant terms here, if you want to develop an implementation team or a small group of people from each organization to meet with our team, that's certainly appreciated as well. I think the more perspectives that we have as we're going through this is going to be really useful to everybody involved. So that'll start here in February. And then we're going to collect all of that data, all of those questions that I just asked. By all means, if you have more, email me, email Kimberly, email Helen, Tina. We want to make sure that we're asking the right questions to the right people. And so we'll collect all that data, we will process all of that. And then at that opening convening session, as Kimberly said, if it's through SAMHSA, it's through SAMHSA. If, we don't get that opportunity, we're going to make it happen here. And then really coming together and start moving this forward. One of the points that Ruth had made, and I wrote it down, was identifying where information exists. That I think that's step number one. And certainly we want to get that moving. So then from there, we're going to be working together, doing some data collection, doing some collaboration. And then as the initiatives start kind of popping up and looking at how we can be strategic in tackling some of these, I'll just say major problems that have no easy solution, we can bring in consultants, we can bring in TA as needed, and really get this moving. So that's all I have. What questions do you have for us? All right. Well, thank you. Oh, sorry. Go ahead.
Something that already makes this said about the dashboard that you're already looking at, what data is feeding into it, what you're using it for, just about that.
So I can speak from my limited scope here. I'm good with developing questions, not so much answering them. So we have our, what we call, oh, okay. Well, I can speak from what I know is our high utilizer dashboard, that we have that we have brought in Ascend, who is really leading that. And what we're able to see is really client information. So behavioral health claims, those are really limited to Adamus claims, which is obviously not everybody in the behavioral health system. And then we do have some criminal justice data feeding into that. Personally, I use it when I am on the fatality review calls, but I think there are other uses for it that Kimberly maybe.
Yeah, hello. I was going to say we utilize this also because it shares the jail information as well as the hospital information, but I also wanted to be able to pass this to Josh. Look at his face. To be able to speak, he's like, oh, no, Kimberly, to be able to speak to this a little bit more.
You're welcome. Yeah, so the Familiar Faces dashboard that we put together for Adamus, it encompasses hospital data. So we have encounters across the entire Greater Dayton Area Hospital Association, both real time through the Health Information Exchange, as well as historical through another data source, and that covers all premier Kettering hospitals. Secondly, we work with Justice Web to have a feed of jail booking data that we incorporate into that. And so those are two primary data sources that we're able to see those interactions. And then as Tristan talked about, the claims data of the recovery board. Now it's a limited picture because we don't have all Medicaid data, but it's a good starting point. And we're actually working on strategies across the state on how we can get access to additional Medicaid data for recovery boards. We talked about some of the pink slip opportunities. So we do have interactions with Dayton Police Department in terms of the overdose and field interview cards, the reports that Helen talked about. We do have that in a standardized format. So these are the things that we're going to be thinking about as we continue to work with Tristan and her team to get feedback on how we continue to bolster the dashboard to incorporate some of the use cases that you all are going to come up with in these discussions. But today, those are the data sets that are intersected. And as Tristan's talking about, the opportunity is what other data sets exist in the community? What are the other use cases for this dashboard such that we can bolster it and build new views for different groups that have different use cases for the intersected data? So hopefully that gives a good enough overview.
You have to be on mic because we're recording.
I think Judge Brandon and I maybe have the same question, but I will not speak for him. But I was curious about what are the plans? It sounds like we've got some concrete plans as far as like expanding and what data we want to look to collect, but what are the plans for sharing with other partners? So for those of us so I work at the public defender's office. So those of us that might come across a client that's in the jail and because of their behavior, we think, oh, I wonder if this person has some involvement, right? I'm curious what the history is here. Who do I need to rope in to help care for this individual? How are we and when are we going to get access to this information?
Oh, sorry.
It's fine, because it's a perfect segue, because I know where we're running a little, we're running just a little bit behind. That's the point of this group. That's the purpose for bringing the folks in who said they wanted to be part of a steering committee for data sharing. And so as you heard Ruth talk, the very first step of that is going to be the data mapping.
He's so far away.
It's going to be the data mapping piece. So stepping into each of your spaces as we identify who the stakeholders need to be for this work and coming to you, spending time setting appointments to see that list of questions that Tristan just listed there. What data do you have? What data are you looking for? We want to avoid getting in front of what we need to build out. We need to know what we've got first. And then what are the restrictions, if any, on data sharing? And then Ascend is our partner. They're our data science team. And as we begin to build out more with the work that we're doing around data sharing, we'll be able to come to a community resolution of that. It's not going to happen immediately because we've got to find out what all is out there. We know what we have, but we don't know what everybody else has. And we certainly don't know what some of those uses might be so that we can ensure that we're being very well aligned or compliant. I don't like that word as much with what our individual regulations might be at a federal level. So, Nancy?
Is there a way to share a screenshot, maybe de-identified, of what you're working with now so that we can see and kind of build on? Thank you.
That would be a great agenda item for the next time we convene this group, perhaps.
I was just curious, a quick follow-up question to what you were saying, Helen. What is do we have like a goal timeline? Like I was looking at the timeline you guys gave us and it looks like maybe this project might wrap up or be ready to launch in August. It looks like August is some sort of end date, maybe given the timeline. What is the timeline for trying to get this database up and running and giving partners access? Like a goal. And I know things never go exactly how we want them to, right? But I'm curious what you guys are thinking.
Yeah. So, and sorry, Josh, for springing this all on you today. So it is one of our priorities with Ascend though, but really because we already have this database, we're going to look at how we give certain individuals access to whatever they're legally allowed to have access to, right? So in terms of, I'm not going to put you on the spot, but within this year, I will say we're going to look at, first off, collecting this information that Helen mentioned, and coming together as a group and sharing, what each organization said, because let's say you want behavioral health data, legally we're allowed to do it, but there's a behavioral health provider that's not comfortable. Like, let's have that conversation. We call those courageous conversations, but I think they need to be had in terms of like moving this all forward. What can we do and what do we feel comfortable with? And then it's just setting those permissions, right? And just giving people logins. So I would think that's doable in a year.
Oh, yeah, it's a big initiative. Way out data, so how do we segment these cases, whether it's the identified, et cetera, so that people have access to them.
Other questions?
Usually when we have done these, we have some type of memorandum of agreement and how this would be used. So if you're representing an organization, you have to make sure that the powers to be who will sign the actual document are agreeable for your participation in the process. So that to us, for the Adamus Board, is key to being a partner in this.
So it's good to
I
have
love
the legal
having lawyers in
perspective.
the room. But absolutely, yes. This would be a memorandum of understanding process. And we will be continuing to have Neomed working with us to help us facilitate this through all of the necessary processes to get this done and to do it in the way that creates a legacy for our system of care so that it transfers. As positions transfer, the information transfers with them so that we don't lose time in some of the work that we're doing based upon movement throughout our system.
Yeah.
I want to say something too. I don't need this. One of the great things that came out of that very first meeting was the case review. There are 2 now that are done, and 2 very difficult clients who are now in good space. That came out of the first meeting of this group. So each time there are going to be little nuggets that get pulled out that we're able to do something with as a full team. And that will be fed back into this group so that we're able to kind of track some of our outcomes along the way so that we get to cheer this hard work. Sarah.
Thank you. So as somebody who is not clinical and probably not appropriate to be in those meetings, I think if that group could work with a communications partner or somebody that Tina knows so that you can give partners in the community and leadership a snapshot of that level of collaboration and communication, maybe something that is filmed but redacted or filmed in a way that you don't know who is being discussed, but you can see the exchange of information, I think could be a very, very powerful explanation of what has to happen in addition to looking at the data. So I would love to see that come out as a part of this work.
Thank you. And I just wanted to say briefly for the Learning Collaborative with SAMHSA, I will be reaching out to gather some information as well as to obtain letters of commitment. So in order for the ADAMIS board to submit the application, we do have to have information from those of you that will be involved. So be on the lookout. I will be contacting you. The application is due at the end of the month, and that would just be additional support for what we are already all working on doing. So I will be in touch. So I just wanted to pass that on.
Are there any other questions this morning? I know we've held you late. It was a great idea to meet at 8 o'clock this morning. I wish we had told the weatherman, but I appreciate that you got here. Right. That's right. Glass is half full. If you have additional questions, please reach out to me. If you have a special connection with someone on our team, you can go straight to them, and we'll be glad to help with any additional information you may need. So thank you all so much. Please take a boiled egg, take a snack, take an extra cup of